Today we have Joanne Spetz, and Joanne is a labor economist who trained at MIT and Stanford, but we'll forgive her that because she's here now. She sort of cut her policy teeth at the Public Policy Institute of California and a postdoctoral fellowship there, and is currently a professor in the School of Nursing in both the Community Health Systems and Department of Social and Behavioral Sciences, as well as at the Center for Health Professions. Joanne has been doing a lot of research on health workforce issues, especially nursing, has been involved with a series of national and California-based surveys for many years, and has recently been a consultant to the IOM Institute of Medicine panel on the future of nursing that just came out with its report a couple weeks ago. So we're very happy to have Joanne with us. She's also one of our campus leaders in interprofessional education, so can speak to the healthcare workforce issues, not just from a nursing perspective, but from other perspectives as well. And we know that in health reform, that's going to be a big deal, to figure out how health reform is going to reshape our workforce, and we look forward to hearing about it. Thanks, Joanne.
Thank you. I was asked to talk a little bit about health reform in the healthcare workforce, and I do know that we have a few people in this room who also have a lot of expertise in this area, so especially when we get to questions and answers, I may very well defer to some of my colleagues here who know a lot about these topics, who now look all a little bit alarmed. So what does health reform do? There are certain provisions in health reform that are related directly to the healthcare workforce, but I wanted to talk about health reform as a big picture package, because it sure is a big package, and I have not read all 1,000 and some odd pages of it. I think I've met one person who claims they have, and I don't know how many times they fell asleep trying to do so. But there's a lot of stuff in that bill. So there are different categories where I tried to group it, and I tried to kind of summarize some of the key provisions. There's insurance and access expansions, which include things that already are starting to get implemented, like denials of insurance with pre-existing conditions. The first requirements on that are related to children, but gradually that rolls out to not being able to deny insurance for pre-existing conditions to pretty much everybody. Insurance companies cannot rescind coverage, so it's not okay to say we give you coverage, oh now you're sick and we're canceling your policy. Lifetime limits on insurance coverage, and then there's regulation on annual limits. Tax credits for small businesses who provide health insurance will be provided, and there's been, and this is roughly an order of implementation, plugging the Medicare Part D donut hole of basically providing some additional subsidies so that there isn't this kind of uncovered period of pharmaceutical coverage. Insurance must provide free preventative care, is gradually getting ramped in with different populations coming first. Insurance access for the uninsured with pre-existing conditions come after the children part, and then the general population comes later, more like 2014. Coverage for young adults on parents' plans, that deadline I believe is like coming up really soon or already passed, because basically all the employers are already doing it, or started doing it early because open enrollment's coming. Coverage for early retirees will hit by 2014 with kind of a phase-in. Medicaid expansions with federal matching funds, funds to community health centers, prescription drug discounts. I mean, there's a lot of different things that are in what I think of as insurance and access expansion. I think the majority of, or an awful lot of this bill and the money associated with it is in these provisions to expand health insurance coverage in the United States, which is recognized to be a big problem in this country. You know, it's rhetorically, when you read the documents, that's also where a lot of the emphasis is placed, because from a political standpoint, it's very hard to argue against you know, people with pre-existing conditions being able to purchase health insurance. You know, so for all of the language about rescinding health reform, there are certain provisions in this that are unlikely to get rescinded, because consumers and Americans are going to view them as valuable and beneficial. And so, you know, I'm not going to continue to read these whole lists. What I am going to do is talk about how, in a few minutes, about how these provisions, I think, affect the health workforce. Boy, these, you know, eventually, here's the one that's very controversial, is personal mandates, which really came from Massachusetts. And back then it was a Republican proposal, but now it's you know, socialism. What does health reform do also in terms of consumer information? There are a few provisions in this that, depending on how you read the bill, could be related to some extent on making it easier to purchase insurance or learn more about your insurance, but it also gets into consumer information. So there is a federal website that is in the kind of launching process related to providing information about insurance options and costs. The idea is eventually people who are purchasing insurance individually could go through these health insurance exchanges, which I think in the ideal vision kind of look like ehealthinsurance.com, where you can find this information very easily about health insurance plans, what they cover, what they cost, what their quality is. Also, consumer assistance programs are to be developed by states that include providing information to help people identify insurance and make decisions about what they should be purchasing. Quality improvement is also in the health reform bill. There is going to be a Center for Medicare and Medicaid Innovation. And there is a lot of, in the summaries of it, the language is a little bit fuzzy about precisely what that center is supposed to do. I think it really comes down to an administrative and kind of executive branch prerogative to say we want this Center on Innovation to be looking at different ways that we can use these public health programs to experiment in what used to be called comparative effectiveness, but that seems to be falling out of favor because some people have decided that comparative effectiveness equals death panels. But the idea of we're going to look at different ways to finance Medicare coverage or to deliver Medicare services or to think about providing care for people who are very poor under the Medicaid program, and we're going to compare those different pilot projects and see what appear to be effective strategies. So there is this quality improvement component. There's also a program that I think is very interesting on quality improvement related to community care transitions for seniors. And there are a few other items in health reform related to community care transitions, home-based care and such that have a lot of quality emphasis in the way they're written. There are supposed to be work in the area of what now I think is more often called value-based purchasing. Some people call it pay for performance. The idea of if you perform badly, you don't get paid as much money. And there's a number of different components of that. And then there's some work related, specific items related to better data and research focusing on health disparities as a particular area for quality improvement need. And thinking about how that data and how that research then later could play into quality improvement programs. This area is much vaguer in the legislation than are the provisions about health insurance coverage. They are much more left in the purview of Department of Health and Human Services to figure out how to do it, which I think is intentional. I think part of it is that a bunch of legislators in Congress have a lot of things to figure out, and they probably aren't in a position to be prescriptive about how Medicare should change its payment structure or its incentive structure to improve quality. Some of it is we don't really know all the answers about how best to improve quality. So there's a combination, I think, of realistic vagueness, and there's probably also some political vagueness that was intentional. There also are components related to cost savings, which seem to be, in a lot of the policy discussion, a central issue. Certainly, we all feel like our health insurance premiums and the amount of money the United States spends on medical care is very high relative to other countries, especially for the quality that we're getting in the big picture. But reading the bill, it's very hard to identify exactly what the health reform bill is going to do with respect to controlling costs. Not that a lot of the other proposals on the table necessarily would do much either. So there's a federal prevention and public health fund that has a lot of things going on in it that focuses on the idea of, by putting more resources into preventative services and public health services, that we should be able to improve our costs and kind of move more of our spending into areas that are more prevention and less urgent care, expensive care, waiting for things to really start going off the rails with a patient and then needing to spend a lot of resources. There's a crackdown on fraud because you can't talk about costs without putting it in the bill, even though I think most of the estimates are fraud is a relatively small amount of healthcare spending in this country. But you got to put it in the bill. States and some review of insurance plan rate increases is in the bill. And we've already seen some of that in California. You get a proposal from health insurers to raise their rates. And next thing you know, you have the insurance commissioner coming down on you. So that's in there. There's supposed to be an independent payment advisory board to focus on the Medicare Trust Fund, which is basically all lowering Medicare costs. And the first salvo in that is an expectation that there will be lower payments to providers in Medicare. Then there's this provision of 85% of insurance premiums must be used for care. And I was just talking last week with some folks at University of Minnesota about that. And that is a weird provision because it strikes me that you could just raise your premium or, kind of adjust your premium and put more money into care and not change your overhead at all and basically have it kind of work out for you mathematically. And apparently the definition of used for care has got some wiggle room in it. So, what about population health efforts? Well, that's care. Well, okay, what about, I guess the definition is getting pushed out to make it easier for insurance plans to qualify under that 85% rule. And then lower payments for the Medicare HMOs. There's some analysis that at least some of the HMOs, or maybe the majority of them, are basically costing people more money and they're pocketing a nice profit as a result. So they want to lower those payments to try to reduce the costs in that program and reduce any perceived windfalls under that program. Some of the other pieces that I think are interesting in this are what are called integrated health systems or accountable care organizations, and I will talk about those in more detail because I think that's not a language that's widely used in the public right now. Electronic billing standards to reduce paperwork because, of course, we have to reduce fraud and we have to reduce paperwork, and that's, that can save some money, but it's probably not the primary way that you're going to reduce costs, or certainly not cost growth in this country. And then there's going to be some pilot programs related to bundle payments. And that's something that has been discussed off and on over the years. And so that's being discussed again. And those, I believe, are going to be pilot programs. And I'll talk about those again in a few minutes. So as I said, very few or relatively few items are really labeled explicitly as workforce items. And now if you start digging into it, you find them littered all over the bill. But these are some of the big ones. Incentives to expand the number of primary care doctors, nurses, physician assistants, loan forgiveness, scholarships and such. There are also going to be funds that go into medical education and health professions education in general, and I'll talk in more detail about those in a few minutes. Higher payments to rural health providers, which are focusing, again, on trying to address disparities and inadequacies in the number of providers in certain regions. Higher Medicaid payments for primary care doctors, and I'll talk about the importance of that shortly. So we're going to cut Medicare payments, but we might have increases in Medicaid payments. Of course, Medicaid payments are so low that it's like you're going from this really low number to a number that's like a little bit higher. We'll see. And then there's this National Health Workforce Commission that people like me who do research are really excited about, but it's like a rounding error in the amount of money that's in this whole thing. So a lot of these provisions, not just the ones that specifically are kind of billed as health workforce provisions, are going to have big impacts on the health workforce. And so, the laundry list of what health reform doesn't necessarily make it obvious what the impact is going to be on health providers or on our workforce needs. And so these are kind of categories that I am putting all of these different provisions, and then I'll talk about how I think each of these might affect our health workforce. And then I think there will be a lot of room to discuss. So starting with increasing numbers of insured people. I think this is where most of the health workforce impact is going to be, is more people have insurance. In general, the research shows that when people have insurance, they demand more care. Now, I know that there's rhetoric about, well, we're going to save money because people won't go to the emergency room, and the emergency room's more expensive, and it'll be better for them to go to the primary care doctor. It'll save us money. And while it is true, it's better for people to go to the primary care doctor rather than to be showing up in an emergency room. The reality is, if you go to a primary care doctor, you get all these screenings done, and you identify things that might need further intervention or further assessment. And that's, again, not necessarily bad. It's okay to spend money on things that have value for us. But you end up with more tests. You end up discovering, oh, your knee's been hurting you and you've been ignoring it for a while. Well, we could look into doing an assessment for whether you're a candidate for a knee replacement. Now, maybe that's going to help the person. That all could be good. Is it going to save money? Of course not, right? You're going to end up spending more money as people have insurance. And this has been demonstrated in a number of kind of broad-based population studies. The very, very old Rand health insurance experiment demonstrated this. I mean, there is a responsiveness. When people have insurance, they tend to seek more care because for them, it essentially means they can afford more care. And that can be okay. That can be something that societally we feel like is the correct investment. Massachusetts gave us a great little case study for this. In 1 year, they had 340,000 people gain insurance just in a 1 year period after that passed. And there were widespread reports of primary care provider shortages, that people found that physicians found that their waiting list to get a first appointment just exploded in terms of how long they were. There was a survey done in 2009 that found in that year 60% of family medicine doctors' offices were accepting new patient, which was a drop of 10 percentage points from 2006. And in that year, only 44% of internal medicine practices were taking new patients. And if I remember correctly, in 2005, it was about 62%. So big drops in the ability of primary care providers to take new patients because they were getting pretty full as these people with health insurance came into the market. Not surprising. So we have a nice case study there. And when you hear people say, oh my gosh, health reform is going to result in all of this additional demand for primary care, this is really based on what we saw in Massachusetts. And we're going to hear more about that in a couple of weeks at the next, at the Chancellor's Health Policy Lecture. It's going to be a great opportunity to learn more about Massachusetts. But I still think, and I'm an economist, so I have to say this, do we still think that there's a shortage? Because in an economic framework, a shortage is a very specific thing. And it's the idea that you're in a situation where you have more demand than supply. And when you have more demand than supply, what should happen in a normal economic market is that you should have a wage increase. In this case, if you have more demand for primary care providers than supply of primary care providers, the wage of primary care providers should increase. And that'll do two things. It'll make more people say, maybe I'll go into primary care. And or people who are in primary care saying, oh, I'm getting paid more per visit. I'll work a little bit longer. I'll work more hours because I know that primary care providers have all this spare time to work more. And also demand declines. In theory, in a perfect economic labor market, whoever's demanding the primary care providers would say, well, they cost more money. So I'm going to go to the doctor 3 times this year instead of 4. Now, of course, does this really happen? There are a few problems. The first is, do wages really change? Right? I mean, we've had reports of primary care shortages off and on for decades. Have primary care physician earnings gone up a lot relative to other specialty groups? I don't think so. Last I read, no, not really. No? Okay, nobody's heard of them really going up a lot. So primary care doctors, we know, earn a lot less than specialists. Just published a few weeks ago in the Annals of Internal Medicine, they calculated average wages and then they looked at average hours, and the median was $86 an hour. The neurologic surgeons, $132 an hour on average. Pediatric subspecialists, internal medicine pediatrics, all around $52 an hour. I think family medicine was kind of down in this range or lower. It's not very good numbers. And these are very interesting, I think, in particular when you think about like the pediatric subspecialists. These folks are in school and residency and fellowship nearly as long as these folks. Some of these like pediatric neurologists, they do a lot of training, but they get paid less than half of what a neurologic surgeon gets. And so these kinds of differences, we haven't seen these change a lot over the decades. So if wages aren't adjusting, then is supply going to increase? Of course not, or at least you wouldn't think so. So when you get to supply, it depends partly on, you hate to say, oh, doctors are in it for the money, but you've got debt to pay, right? There's debt to pay, there's hours to work. Money is a factor, there's no question. And so supply will depend on that. It'll also depend on medical school admission spots and residency spots. And the reality is, for most academic medical centers, primary care medical education is a money loser. But if you have more residents doing cardiology, you can make more money as a medical center off of your cardiology program. So the whole institutional structure focuses on the specialties. Earnings are a factor, as I mentioned, and then also in supply, International medical graduates are a big factor in the U.S. primary care supply, and I'll talk about that in a couple of minutes a little bit more. On the demand side, in theory, if prices go up, demand should go down. But demand doesn't go down, partly because people have health insurance. And once you have health insurance, you pay $20 a visit, or you have totally free visits depending on your plan, or you pay a flat copay of 10% or 20%. So you don't see the full cost. So if the cost of a primary care provider visit goes up by $15 or even $100, and for you it means you're going to pay still $20 a visit, or maybe you'll pay $5 more, is it going to affect how many times you go in? Probably not a whole lot. Right, so demand doesn't adjust a lot. Plus we have this health reform thing that's going to really push up demand, if nothing else. So we have a shortage, we think we have a shortage already. We have these factors that are going to push demand up. We have a lot of reasons that we think that supply is going to stay low without some intervention, and wages don't naturally respond. So we have these ongoing shortages, which are a problem. So this is a chart that came from Health Resources and Services Administration and the American Academy of Family Physicians of primary medical care health professional shortage areas. So these are kind of officially designated shortage areas. Red means the whole county is a shortage area. Everything that's kind of this yellowish color here means at least part of the county is designated as a shortage area, and then the lighter colors basically mean it doesn't meet shortage criteria. So pretty much everywhere has some degree of shortage. I mean, it's kind of a scary map. And some areas have more than others. One of the reasons that I mentioned international medical graduates, there is a priority visa. You can basically get a visa if you agree to work in a health professional shortage area for some amount of time. So if you go around parts of California where these shortages are endemic, you will find that a lot of the medical community providing primary care is international medical graduates, which is just kind of an interesting thing. And you know, there's a lot of debate about whether that's good or bad, or whether the care provided to people in those communities is as good or bad. I think probably one of the more pertinent issues from a global perspective is these international medical graduates are often coming from countries that could use them and, you know, could use their own doctors. So there are a lot of very complex ethical and quality issues that could come around that, but it is one of the ways that we shore up our primary care supply. It's what we've been doing for quite a long time. So these are some forecasts that came from the AAMC, American Association of Medical Colleges. They always do forecasts of physician supply and physician demand. And you know, a cynic would say, well, they're representing medical colleges, so they always want there to be a shortage so they can get more federal money to support medical colleges. I mean, that's the cynic's view. But you know, a lot of their forecasting work is pretty state-of-the-art and pretty solid stuff. And this is their baseline model. No health reform in this model at all. This is just baseline of if you look at what population growth is going to do for your future demand of physicians, and then you add to that the impact of aging. And that's kind of some baseline estimate of the increase in demand for services. You know, the population's growing, so we'll need more doctors due to that. But then also, as the population continues to age, due to the baby boomers moving up through the age groups, we're going to have even more demand for services as a result of that. Or as I often joke, all the nurses are going to retire just when they want their knees replaced. And now what do we do? So they there's a whole series of slides that they just presented, I think, last week, I think it was at the AAMC conference. They have a big annual conference. And these are their demand supply forecasts. They're assuming that utilization rates continue to rise, that there'll be shifts in work schedules, there'll be some growth in graduate medical education, and some increase in productivity, which is kind of code for, you know, we all take care of more patients with fewer doctors. Their most plausible supply numbers based on kind of current trends are way down here. The most plausible demand numbers are way up there. Big shortage forecast, and that's kind of, I think a lot of that analysis was done before health reform had really passed, although the date on the report is kind of right after. But it wasn't clear to me fully how well they'd incorporated the long-term effect of health reform in this. So then they broke it out by specialty, and I think this is very telling. If you look at specialties, where are the biggest gaps? Primary care. right? In terms of numbers and in terms of like number gap and number of people working in the area. That's where the big gap is. Surgery, we're hearing more and more general surgery is a big factor. And then the medical specialties, not much of a gap estimated down there. And the circles are the supply number. So there's still supposed to be a shortage of specialists, but even at this point, the AAMC is saying, primary care, general surgery, that's where we have the gaps. This is an analysis done by the Lewin Group. They have some people there who do some really nice work on forecasting. The orange basically means that only 80 to 90% of the demand is met for primary care services. And then the red is 80% or less is met. And then this lighter color is that you're kind of more or less balanced. And then the green is that you have kind of more doctors than, as far as we can tell from the models, than you need. So, there's Minnesota looking really good, cold but good. So pre-health reform, these are their estimates. That Mississippi, really, really not good. A lot of other parts of the U.S., not great. Not a lot of areas where you're feeling like the market is super balanced or even in a little bit of a surplus. Post-health reform, the map gets pretty ugly. A lot of these areas that were orange before have gone red. And Minnesota's still okay. But even Washington State, which in the previous pre-health reform scenario looked like it had a little bit of a surplus even of physicians, is now moved into a balanced market, and then you can easily imagine, depending on what happens with health reform or graduate medical education, that it could move into a shortage area. So California stays in a more or less balanced market thanks to fabulous medical universities like UCSF, but we need to send some people to Nevada, clearly. I mean, these are health professional shortage areas at the sub-state level, right? So these are all counties. So you can see that within a single state, like Texas, they go from whole counties being shortage areas to regions having no shortage at all, right? And so that's what you see, this tremendous variation. So the state models that Lewin Group releases masks what might be going on at the sub-state level. For nurse practitioners, these models do assume, I think, a little bit of a movement towards nurse practitioners. But I hear the same anecdotes that you do about nurse practitioners moving into hospital settings because the primary care jobs aren't available to them, especially in places like the Bay Area, where we have a lot of doctors and a lot of NP graduates who don't really want to leave the Bay Area. I mean, I think if you went to other parts of California, where I've heard people talk about Nevada or other states, it's easier for nurse practitioners to find jobs. We'll be able to tell you more in a few months because we're doing a survey of nurse practitioners in California for the Board of Registered Nursing. And it's exactly the kinds of questions we're asking of, are you finding it hard to get a job in kind of basic nurse practitioner work? So, we don't know a lot about it. We don't have a lot of information on that topic. Phew. So that was the first major provision, right? Expansion of health insurance means demand for more health care, means demand for more primary care, we think in particular based on the Massachusetts experience, based on the fact that we already have shortages in those areas. So we haven't even started talking about some of these other areas. Fortunately, a lot of the rest of these are comparatively quick. Yeah. So the question was, could you or has anybody looked at these shortage areas and then what the earnings are for physicians or the wages are for physicians or other providers, nurse practitioners or anybody in those areas, and whether the areas that have the shortage tend to be the areas with the lower payments? And I suspect somebody has done that. I mean, there's a lot of research in this area that I haven't read or that is not coming to my mind right now. But I think in general, the payments for providers and the decisions about providers where to locate, there's some evidence that those decisions are often based on the overall geographic amenities and not necessarily as much on how much they get paid. So you wonder, if you increased payments for rural providers by 10% or 20%, would you really get that many more people moving to Coalinga? You went to medical school at UCSF, you lived in San Francisco for 4 years, then you did your residency at Stanford, so you've been in the Bay Area for 7 or 8 years, and now you're getting recruited to go to Coalinga. How much do you have to get paid for that, and how long will you stay there? So it's much more complex than just wages, which is part of what makes the underlying economic theory of, oh, well, if you just pay more, they'll all go there, a little bit suspect in this regard. So, I'm an economist, but I'm pretty willing to be critical of the economic models for those reasons. I think there are a lot of reasons that affect where people choose to practice. And maybe what you should be doing is having more residency programs and having more education programs that spend a lot of time with practice in rural areas so that people become very comfortable with working in those communities and those environments, which is why UCSF, of course, has a Fresno program to help work with that community and work with people who might want to pursue medical practice in the Central Valley so that they get deeply involved in it from the get-go. So Janet's comment about one of the factors that we might see here is that some of these states have had very, very low Medicaid eligibility thresholds. So it's hard to get qualified for Medicaid, and the expansions of Medicaid under health reform, therefore, are going to bring health insurance to a lot of people. And so that pushes up demand side. Another factor that could play into this as well is the overall uninsured rate, because Medicaid is only a piece of the puzzle. Now, California has a fairly high rate of people who are uninsured, but we also probably in the big picture have a somewhat better supply to help balance that out better than, say, Nevada or some of these other states. And these comparisons also mask other factors. I mean, there's an old classic paper by Victor Fuchs where he, it's like, gosh, I can't remember the lead of it, but the subtitle is A Tale of Two States. And he does a comparison of health metrics, health spending, vaccination rates, how much money is spent on healthcare, physicians per capita, and a whole bunch of other metrics across two states. And says, okay, for these two states, now I'm going to show you the health outcomes. And in one of the states, the health outcomes are far, far worse than the other state. And then he reveals that one state's Nevada and one state's Utah. And you can say, okay, so Utah might have a health professional shortage, but the data that we know is that their outcomes are pretty good when compared to Nevada. Why do you think that is? I mean, personal behaviors do play into, in the big picture, what outcomes we see. So I don't want to say that these differences in health professional supply, demand, or shortages strictly are going to be tied to health outcomes, because workforce is only one piece of what drives your health outcomes. It's certainly an important piece that, we like to think is very important since we work in an education institution that focuses on health professional education. But other behaviors are very important, other factors are very important, which is why I think, there is a provision about public health programs in the health reform bill. Preventive care. This is a short one because we've already talked about preventative care to some extent. We expect that the focus of preventive care in the health reform should increase the demand for primary care providers, kind of above and beyond what you would expect in a normal health insurance expansion. And I think there's a recognition in reading the legislation that some of that care, or maybe much of it, could come from nurse practitioners, physician assistants, RNs without advanced specialty preparation, and other kinds of health professionals. And so there is some recognition of that. There was, from what I understand, some backroom politicking about whether there should be a requirement regarding scope of practice expansion for nurse practitioners, but Congress in the end realized that that was a deal killer. Basically, I think some of the lobbyists said if you do this, then the AMA is going to lobby to kill it. So it's back at the state level on that standpoint. The law does recognize, though, the importance of other workers. There are grants to promote positive health behaviors and outcomes in medically underserved areas through, for example, the use of community health workers. So there are explicit provisions regarding community health workers being involved in promoting health and promoting healthy behaviors and trying to improve outcomes. So it's nice to see a bill where it's like, oh, there are other health professionals in there. It's good to see. Community health centers are going to be expanded under health reform. And this, again, we expect should increase the demand for primary health providers. It also probably will increase the need for health professionals working in underserved locations like rural areas and center city areas. because those are the areas where a lot of community health centers are located. The rural areas being, if you remember the map with all the speckled colors, it's the rural areas that tend to have the shortages, much more endemic shortages. You can have a center city community health clinic that has a hard time recruiting, but they are at least in an urban area where there are people probably willing to commute there. But when you're talking about a rural clinic that's really truly like in Coalinga, I did a couple of projects in Coalinga, so I've been there a lot. And Coalinga is a long ways away from everything. It's like 50 miles to the nearest hospital. And so it's hard, you can't easily get people who are going to commute there. Some people do. Some people commute there from Fresno, and it's kind of amazing. And their hospital doesn't have maternity services anymore. So, you're in labor and you get to travel an hour to get to the hospital to deliver. It's really a different environment. And so they find it very hard to recruit doctors and to recruit people there. It's just a different situation for them. There also are provisions related to training and education in community health clinics, which I think is really interesting. There's new federal support for teaching health centers. That's the language that they use, which is new or expanded primary care residency programs at federally qualified health centers, community mental health centers, rural health clinics, and health centers operated by Indian Health Services. I think that's really interesting. What they're trying to do is provide explicit support to have residencies that are outside of academic medical centers or are affiliated but more distant or are further away, where really primary care is what you do. And you're not doing a primary care clinic that's based at a hospital. So it's a model that I think a lot of people in primary care have said, yeah, it's a no-brainer. We should be moving in that direction. There's also some money, which UCSF just received a grant in the area of nurse-managed health clinics. The GLIDE services, the GLIDE program that is run by the Department of Community Health Systems, received a grant for this to support nurse-managed health clinics. These are clinics that have to be affiliated with a medical group or an academic health center like ours is, and these programs have to focus on primary care or wellness services, and they are intended to also have an educational component in them. So the adult nurse practitioner students in the Community Health Systems Department, many or almost all of them, I'm not sure what the ratio is, do some of their education and training at GLIDE, which is a great opportunity to work with the community, and the department basically runs that system. It's a fabulous system. So that area has some interesting health workforce components to it. There's also several different provisions, and these are just a couple of them, related to home and community-based services. There's home and community-based services for disabled people with the focus on trying to keep people from being in more of a skilled nursing institutionalized type of situation. Community care transitions to help move people out of hospitals or nursing homes into community settings, and how to do that effectively, and what kinds of health professionals do you need to guide that process. And I think that these are going to have a big factor. You're going to have community health workers playing big roles in these kinds of programs. RNs play big roles as care coordinators, home health providers, and so on. Even nursing assistants, certified nursing assistants, can provide basic care services and can serve a role in a home care setting with providing assistance in daily living activities and so on. So there's a lot of opportunity in this to push towards more support for health professionals outside the MD area. Because most of the rhetoric that we hear, or most of the policy discussion, I think, is focused on the primary care physician shortage. But there are all of these other areas where there are opportunities for development and opportunities for growth. I had some great conversations in Minnesota last week. I'm really glad I went to meet some folks in the Carleton School related to the value-based purchasing and the bundled payments. There's some interesting stuff that's going to play out there. So value-based purchasing is the new term for pay for performance. And basically right now, if I were going to be pretty broad brush about it, providers generally get paid the same amount of money whether they provide mediocre care or excellent care, right? Are hospital reimbursements different if you're the best hospital in town or you're number 5? Not really. Now, if you're number 10 out of 10, you probably get penalized in some way, right? You probably get fewer patients, insurance companies drop your contract, whatever. But if you're somewhere in the middle, you probably do just fine. So then what's the incentive to invest in things that are going to cost you money to improve quality? Now, of course, we like to think that you're going to do it out of the goodness of your heart, but a lot of hospitals have pretty darn tight budgets. There are periods of time in California within the past 10 or 15 years where more than half the hospitals in California were in red ink. So, there's not necessarily a ton of money in hospitals to invest in quality improvement activities, and there certainly is very little to no incentive to do so in the historical payment model. So value-based purchasing is basically trying to say, we're going to change this. We should change this. We should be rewarding excellent performance. And some of this debate, it kind of sounds like teacher payments. Should you pay teachers bonuses for better student performance? But what if they got a class of kids who are all naturally better? Should you pay a hospital for better performance? But what if they strategically manage to get all the patients at lower risk of dying anyway? So it's complex to pull this off in a way that's kind of scientifically defensible. But an example that is pertinent for some of the work I've done on nursing workforce issues is that higher nurse staffing is pretty clearly shown in a whole variety of studies to be associated at least a little bit with better patient outcomes. There's some debate about which outcomes and which ones are more versus less, but there's a preponderance of studies that show that there's at least some relationship there. Now, RNs are expensive, and their cost is not billed directly. So if I give a patient 8 hours of nursing care versus 10 hours of nursing care, I don't get to bill differently for that. It's all in the day rate that I charge, which ends up being negotiated through, these Byzantine negotiations with insurance companies. So as a hospital, I don't really have a financial incentive or even the reimbursement available to me to hire more RNs to provide more care, even though I know that it might improve my outcomes. The theory is that pay for performance could mean that if you do have higher quality outcomes, that you will get paid more money. So now you have an incentive to hire more RNs to achieve those higher outcomes and thereby get more money to help pay for the nurses that you hired to get it. A little bit circular. I feel like there's a chicken before the egg problem here. Like, you're going to hire the nurses because you think you'll get better outcomes, but then if you miss your targets, you're going to have to lay them all off, or, who knows? It's a little bit fuzzy exactly how it'll play out. But Medicare has done some demonstration projects in this area, and the demonstration projects, the outcomes I've seen published, look reasonably good. Medicare is, that's kind of the carrot side. We're going to provide incentive payments for hitting various criteria. Medicare also has implemented the stick, which is we will not pay for these set of outcomes. If these things happen, we will not give you any additional payments for them. And an evaluation is underway for that now. Research Triangle Institute's doing the primary evaluation of that. Now, payment bundles are a slightly different notion. For these, hospitals would receive bundled payments that cover the hospitalization and would cover post-acute providers for 30 days after the hospitalization. But if you had readmissions, like, oops, we let them go too soon from the hospital, you would basically get paid less if those patients are readmitted during that 30-day period. So the notion is for hospitals that we're going to try to bundle up the payments to make sure that you're not discharging people too early and to give you an incentive to coordinate the post-acute care, the transitions to rehabilitation or home care or whatever is appropriate. So that could affect some of the ways that hospitals think about delivering quality of care and what kinds of people need to be involved in deciding, are patients ready to go home? What kind of post-acute care do they need? Do they need physical therapy? Do they need a care coordinator? And how does a hospital need to do that? Now, the piece I'm very intrigued by right now is these integrated health systems, the accountable care organizations. So what the heck is that? Great, we have another acronym we all have to learn. We have to learn what an ACO is. So these are supposed to be organizations that provide and manage the continuum of care across different settings. And there are different guidelines that are coming up. So these are ones that Devers and Berenson published, and I think I just saw that there's some other set of guidelines that are coming out now from the AAMC actually it was the AMA. The AMA just released their own guidelines, because not only do you need to provide and manage this continuum of care, but doctors need to be in charge because it's the AMA. You need to have the capability of having prospective planning budgets and being able to prospectively plan your resource needs. And you need to be sufficiently large to have comprehensive, valid, and reliable performance measurement. So basically, you're a big organization. You manage care across multiple settings, from ambulatory care all the way through the inpatient and potentially post-acute care. You have a prospectively planned budget, and you're big enough to have performance measurement. Now, who is this? Kaiser Permanente, yeah. I mean, there's few of these. But, you know, so what are they going to do in health reform? There's supposed to be a pilot program, 3-year agreements with Health and Human Services. They have to have a minimum number of Medicare beneficiaries. So they have to be big. You have to have at least 5,000 Medicare enrollees. You have to have defined processes to promote evidence-based medicine and patient engagement. You have to have reports on quality and cost, and you have to demonstrate patient-centeredness, although we're not quite sure what that means yet. It's not like written out in the rules yet. And then these organizations would get a percentage of the cost savings that they realize. So some of the cost savings go back to Medicare. They get to keep some of the cost savings that they realize. So yeah, pretty much Kaiser, maybe like Group Health of Puget Sound. I mean, how many of these are there in the country, really? I'm hard-pressed to come up with many, right? There aren't that many, nationally speaking. So if you're in a place where there is none, or you aren't one, and you think, gosh, I'd like to get that money. I mean, there's profit sharing here, right? I want some profit sharing. How am I going to do that? If you're a hospital, you go buy some medical groups, right? If you don't have them already, you go buy them. And if you are a medical group, you buy hospitals. Now, I think it's more likely that hospitals are buying medical groups. And in some parts of the country, this is what you're hearing. You know, that from a business school strategy, hospitals are kind of going to the business school consultants and saying, so we want to come up with a strategic plan to become an ACO. We need to buy some medical groups. You know, can you consult with us to do this? You know, and then are they going to be able to do that in a way that achieves the kind of ACO vision, which is a pretty holistic vision? Yeah.
Medicaid count there, or it has to be Medicare?
The question was, does Medicaid count? And my reading of it is it's Medicare. So you have to have the Medicare beneficiaries. But you could imagine this kind of a program extending out to Medicaid. And there are some, like, you know, Alameda County Medical Center has a set of federally qualified health clinics associated with it. And most of their patients, for example, who show up in their emergency room come from their community health clinics, and most of the people they discharge go back to their community health clinics. So they might, but they don't have as many Medicare patients. They're more of a Medicaid provider. So they might arguably be an ACO, but they don't probably have the right population to tap into this funding stream as a pilot project. Same thing, same thing. Yeah. Right. So the comment was that CMS does have interest in Medicaid patients being involved in these pilots, but that they, you know, the question is, do you have critical mass, really? And there are public health systems or safety net providers that have dually eligible patients, which may be an opportunity to have Medicaid, Medicare, you know, kind of come together. We'll have to see. I mean, this is still very much in development, but I think it's very intriguing, this this sense that I've heard from some folks that there are going to be hospitals trying to go on a buying spree and trying to figure out what medical groups they can buy. And in the cases where they already have bought or affiliated with medical groups, then what they can do to try to tie that tightly enough that they can go after these pilot programs. Yeah. So the question is, do I know what % of physicians are already kind of employed by hospitals rather than being independent? I don't know that number, but I think it's also a complex number in that I think a lot of people tend to think of Kaiser doctors as employed by Kaiser, but Kaiser's medical group is a separate entity that is not employed by the Kaiser hospitals or health plan. It's a separate medical group with an exclusive contract. So then if you were to look at data on, like if you did a survey and you said who employs you, they would say I'm in a medical group. They probably wouldn't say I'm employed by a hospital. And so it would be very hard to extract from the data and surveys that I can think of really precisely what that is. You'd have to get into questions like, so is your medical group associated or owned by or affiliated in various ways that are rather complex with your, you know, with some kind of a local hospital? It gets a little bit tricky. It reminds me vaguely, for those who were here a few weeks ago, of when Lawrence Baker was presenting about the question of whether a medical group owns a scanning device and what all the rules are about that, and that there are these complex things where you can kind of lease it for every time you use it, but then you don't, so you own it for those, 20 minutes that it's being used for your patient, but you don't own it other times. And, reading this stuff, I'm like, oh, there's some opportunity for gaming here if people aren't careful. This could be implemented in ways that basically makes the whole idea of integrated health systems look bad. And of course, the premise is that these, part of the reason that this made it into the bill is that there is a reasonable amount of evidence that these, when done well, are very effective at controlling costs and delivering high quality. But they can be done badly, and if they're done badly, who knows what'll happen. Same thing with the Medicare Advantage, right? The Medicare HMOs. The general data is that Medicare HMOs cost people more money than being a fee-for-service Medicare enrollee. But that's not true for every Medicare Advantage plan. The ones that save money and do deliver great care and so on end up kind of getting tarred with the rest of them. And so we'll see how it plays out. And then there are the workforce provisions. So a lot of what I've talked about are things that are going to drive changes in the demand for healthcare services and therefore changes in the demand for healthcare professionals to meet those service needs. So what about the supply side? Well, there's incentives to expand the number of primary care doctors and so on. Rural health, I mentioned all of these. So I'm going to talk about the first three as a bundle because there's just a lot of different things that kind of apply in all of those areas. One big area is an expansion of the National Health Service Corps, which is a program that repays educational loans and provides scholarships to primary care providers who practice in shortage areas. And that includes nurse practitioners and physician assistants. It's not just an MD program, although MDs, I think, are the dominant share of the program, but it's not just them. This program and other programs with kind of similar intentions in the Health Resources and Services Administration had substantial cuts throughout the kind of the early part of the 2000s. And so some of this is almost bringing these programs back from, the brink where they had been pushed down to. And so, those people who, right now it's like, ooh, these expansions, like, hopefully we'll get ourselves back up to the level we were at once before. There'll also be there are tax benefits for working in rural areas. You get these various tax breaks that I'm sure only somebody in the IRS can figure out. There are scholarships available for disadvantaged students who say that they will work in medically underserved areas as primary care providers. I mean, these programs exist now, but they're really going to expand the money that go into a lot of these programs. They're also going to put an effort into, out of this Prevention and Public Health Fund that I mentioned earlier, some of the workforce money is coming out of that fund to create additional primary care residency slots with a target of 500 new MDs by 2015, which means we better expand those programs really fast. Right? You need to have the programs take the students by 2012 to have them on the street by 2015. It's a pretty tight ramp up there. PA training in primary care, nurse practitioner training, the nurse practitioner-led clinics, and then money for state planning to meet increased primary care demand. I know California was putting in a planning grant, and we did get it.
California has so many in all 5 of these slots.
Yep.
About 2/3 of it is in the primary care residency training, some of it is coming UCSF.
Yep, so these funds are mostly administered by the Health Resources Services Administration's Bureau of Health Professions. And California's got money coming in all of these. Of course, you would hope so, since we're the most populous state in the country. But it would have been kind of bad if we didn't. But we have money in all of these areas, including a planning grant to work on thinking about what our primary care demand needs are and health workforce needs in general. There's other training money. The question came up about what about the supply of community health workers, aides, and these other health professionals that don't come out of UCSF and such institutions. So there's Department of Labor funding that has tended to focus on low-wage, low-skill workers. That money is going to continue to go in those areas. A lot of that's Workforce Investment Act money. California has been one of a number of states that have been pretty aggressive using that money for things like basic RN education and other health professional areas, LVNs and CNAs as well. But there's some proportion of WIA money that historically, some people call it demonstration funds, some people call it the governor's discretionary money. It's basically money that doesn't have to be used for the traditional welfare to work type programs, and that there's some discretion about how you use that funding as long as there's some evaluation of the effectiveness of that use. So California has put, since 2002, has been putting some of that money into nursing education efforts. The first program was Governor Davis's Nurse Workforce Initiative, and then Governor Schwarzenegger launched the Nurse Education Initiative, because you can't use the same name if you're a new governor. And there have been a couple cycles of the Nurse Education Initiative. So that WIA money, I would expect, is going to continue to support a variety of health professionals. There's even money coming in from Department of Labor related to health informatics workforce, which as far as I can tell is the computer techs who are going to figure out how to string all the wires, right? It's community college education. So it's not, informaticists with masters and doctorates. It's kind of the IT guys, right? You think of the IT guys and girls who are stringing your wires, and it's that kind of training. There was a reinstatement of a special line of dental funding in the Public Health Service Act that was previously kind of had been lumped in with other stuff, and then grants to establish training programs for alternative dental healthcare providers. So even the oral health needs are being addressed from a supply side. Grants to nursing schools or healthcare facilities with nurse education. And then there's a set of grants that are going to be coming out of the Bureau of Health Professions related to career ladders, internships and residency programs, and additional kind of higher education for advancement in the profession, which includes trying to increase the supply of faculty in these areas. So there's money in the nursing side. Everybody gets some money. Medicare and Medicaid payments are, they're going to be incentive payments for primary care providers and increases in Medicaid payments to primary care providers. We'll see how those play out. It seems like some of that might be, at least for California, just trying to get Medicaid payments back up because there have been cuts there repeatedly. So one would think that these things could increase demand for primary care education and demand for people to go into these specialties. We'll see. We'll see if the increases are large enough to really push the supply where, in theory, it should go. And then there's this National Health Workforce Commission that geeky data people like me love. So this commission was appointed in September. The chair is a nurse, Peter Buerhaus, who is at Vanderbilt University, who is, I think, widely regarded as a general health workforce expert. He's been directing a health workforce center at Vanderbilt for a few years. In California, Kathy Flores is affiliated with UCSF Fresno. She's on the committee. I think she's the only California person on the commission. I could be wrong. I know the other people who followed this are kind of going, is that right? I think that's the only California person on the commission. She's the only UC person on the commission. The commission list, it's fun to look at. There's a good list of people who are associated with this. My understanding from talking with Dr. Buerhaus is that they have enough money to have a meeting, and beyond that, they're dependent on appropriations. So they're going to have a meeting, and they're going to talk about what they should do, and then we'll see. We'll see what happens. There's also this National Center for Health Workforce Analysis in Health and Human Services, and there is language about having state and regional centers supported by Bureau of Health Professions to support state and local data collection and analysis, but exactly what that's going to look like is still under formulation. But ideally, they're supposed to be collecting and analyzing data and supporting the work of this National Commission and some of the state planning efforts that are coming out of these planning grants. Yeah. So the question was, what parts of this are kind of already baked in from a funding standpoint? And my read of it is painfully little. The health workforce provisions, I think a lot of it is authorized but not appropriated. And so, so you may have just brought me to my next slide, which are the issues to pay attention to. So we have a new House, if you didn't hear about that. And it's going to be very interesting to see what happens. I mean, there's a lot of rhetoric around repeal, and but you have a Democrat Senate and you have a Democrat president, and you could pass a repeal bill from now until the cows come home, and the president's going to veto it over and over and over again. So I suppose if you want to spend the next 2 years doing that as a political strategy, you could knock yourself out, but it's probably not what Americans are really going to stomach more than once or twice, maybe not even once. You can kill this thing with appropriations, right? You could choose to not appropriate a lot of provisions in this. You could choose to give Medicaid so little money that they can't do these innovative pilot projects. You could choose to cut HRSA's budget so much that they can't have a workforce commission and they hardly have enough money to do these loan programs. I mean, there's a lot of room to kill this whole thing with appropriations. You know, and the insurance protections and those things don't require an appropriation. So the insurance protections for consumers and all of the, you know, all of that stuff happens anyway. The Medicaid expansions could get hit pretty hard by appropriations stuff. And then all of the supply side stuff, all the cost effectiveness stuff, all the stuff related to trying to control costs, that's all dependent on appropriations. So interestingly, for all of the, I mean, the political rhetoric is about, we really need to not spend all this money, we need to focus on controlling costs. The way that the politics might play out, all of the cost increasing provisions are going to happen probably no matter what, and then the cost savings provisions are going to be the ones that get axed. Now, what I've heard in terms of strategy, I think one of the bigger things that is going to hit is there's going to be a huge push for the purchasing health insurance across state lines. That proposal was originally put forward into this bill by the Republicans, and it never made it in, and that is going to absolutely come out of the gate in the House. And it's not necessarily a bad proposal. There are pros and cons, but there is some simulation evidence that you could increase the insurance coverage in many states by allowing that to happen. Now, the trade-off is you lose some protections as a result of that. Maybe the federal protections that are in health reform help make up for that, and it'll be an interesting political debate. Well, so the question is, how would that interact with the requirement for essential health benefits? Well, that federal requirement applies to every state. So if, you know, Louisiana did not require that health plans provide XYZ essential health benefits, and that's the history, then if Californians can now buy health plans that are based in Louisiana and under Louisiana law, you wouldn't get those protections. But federal health reform now gives you those protections that would be in every state. So maybe, you know, maybe it's less of an issue. But then maybe there's less cost savings because now you can't get the cheap plan in Louisiana that doesn't, you know, cover pap smears. You have these essential protections. So it's kind of, I'll be curious. One of the people I know at Minnesota who I argue with frequently is advising McCain. So I'm always like, so Steve, what's McCain going to propose? You know, and they've been very big on the health insurance across state line issues. You know, and the simulation models I think look promising. You might be able to save a little money there, but I certainly wouldn't be hanging my whole hat on that as a proposal. It's like, well, if that's the best you can come up with for common sense reforms, you know, we'll see. Not that it shouldn't be done, but it certainly doesn't. It's not going to get 100% coverage, and it's not going to bend the cost curve all that much. Responsiveness of medical schools. I mean, there's a lot of lobbying that's going to go into how all of this plays out. So health professional schools could play into it. You know, there's a lot of money and a lot of focus right now on increasing RN education, but the community colleges have a strong presence in nursing education and may want to try to play a bigger role. You know, states may or may not be successful in their planning. I think California has actually been reasonably proactive in its planning regarding its health workforce as compared to a lot of other states. States, you know, there's a lot of stuff in here about health insurance expansions, children's health insurance program expansions, Medicaid, and states could follow those more or less strictly. And I'm sure that there are ways that you could interpret the laws and the provisions to implement very, very narrowly or more generously or more in the intention of the provisions that could affect what happens in terms of the overall access to care for the uninsured. Health professionals, you know, they do have this tendency sometimes to behave as if they're in guilds and circle the wagons against each other. Well, we really like this idea of community care transitions, and we think that there should be a new medical specialty of a community care transition MD so that we can do that. And, you know, and by the same token, RNs are going to be saying, no, we can do that. And everybody's going to be pushing the scope of practice issues. You're already seeing that when the Robert Wood Johnson Foundation's Initiative on the Future of Nursing report recommended that all nursing professionals be allowed to practice to the highest level of their training and knowledge, that the medical associations immediately had stuff up on their websites about how NPs don't provide good care. And I mean, it was very, I think it was probably embarrassing to a lot of the MDs I know who work with NPs, who were kind of like, really, did you have to say that? But you get that behavior that could stymie some of these efforts towards a more interdisciplinary workforce. And then these performance-based and cost control issues that are aimed at both cost control and quality improvement may or may not be successful. Imagine if all the appropriations do go in, like there's envisioned. If all the appropriations do go through, it still could be that the medical homes don't perform like we think they will when launched on a broad scale, or that the accountable care organizations just become, kind of the wolves in sheep's clothing, and almost none of them really look like Kaiser. Or, performance-based payment becomes the equivalent of teaching to the STAR test. And, and then we will all be back to saying we haven't controlled costs, we haven't really improved quality, we're spending a lot of money on health insurance, and we're happy that people have health insurance, but we still have a cost problem, and we still have a quality problem. And, so I like to think that the glass is half full, and that there's a lot of promise in this area, but, but I'm enough of a cynic, or maybe realist, to know that there's a ton of opportunities for this stuff to go off the rails. And then we will be back to revisiting the cost issues and the quality issues that, honestly, I think weren't fully visited during the first push for this legislation to begin with. I mean, I think there's a sense of we're going to go back and keep working on it and fixing it, and that'll be in a political process. We'll see what happens. So that's kind of the end of the formal comments. And so there have already been some good questions and comments, and I'd love to hear more. Yeah. Oh, well, that's a great question. So the question is about, is there any discussion now about the problem or the difficulty of nurses who are graduating now from basic education programs having a hard time finding jobs? And that's a great question. We don't have a lot of data on that problem right now. There's a general sense that because of two factors, both the reduced demand for health services in general due to the recession, which has caused people to lose their health insurance or to have less discretionary money to pay the co-payments for the knee replacement or whatnot, that the demand is a little bit lower for healthcare right now. And on the other side of the market, if you were a nurse and you were working part-time and your spouse was a real estate agent, you probably are working full-time now. Right, you picked up another shift. You're working more. So you have this increase in supply. I was talking with somebody at Kaiser who said they had a whole model about how many people would retire from their nursing staff over the past 2 years, and like none of them retired. Right? They know they will at some point, or they're going to die on the floor nursing. But they're going to go away someday. So then, if you have this increase in supply at the same time you have a little bit of a reduction in demand, and you're a new graduate, it's very hard to get a job. And so I think there's a sense that as the economy improves, that should get better. But I also think that's why in this legislation, and also in the Robert Wood Johnson Institute of Medicine Initiative on the Future of Nursing report, there's a pretty strong recommendation about creating RN residency programs and continuing education opportunities for RNs. The problem is that hospitals, because of their budgetary situations, don't really want to pay for it. So supposedly some of this money from, if appropriated through health reform, will help to pay for those programs. But, right now there's a lot of people who are saying this is a really good idea, we really should do this, we really need to move forward on this. How well it's implemented or whether it's implemented quickly enough, I think is a big question mark. It doesn't seem like it's moving as quickly as it needs to right now. And so, and I worry about this. You get this big cohort of new graduates who, if they can't find work for a certain amount of time, decide to go do something else. Right? I'm telling them go back to school, get a master's degree, get the doctorate, stay in school. It's not, it's kind of as best a place as you can hide as possible. But then of course you get the student debts and all of these other concerns surrounding it. So it's not pretty. I'm not liking it. Right. So Janet's point is that the perception of surplus nursing graduates is very regional. And so in the San Francisco Bay Area, there is a sense that we have a surplus of graduates right now. In the Central Valley, in some parts of the Central Valley, there's a sense that there's a shortage. I talked with a colleague at University of Nevada, Reno, and she's like, send them my way, I'll take them. So, what I'm telling friends of mine who are finishing nursing education programs is if you can get out of the Bay Area, do it. And I've heard some nurse execs, I think this is crazy, but I've heard some nurse execs say to students as they're graduating, don't take a nursing home job, because when you then later try to get a hospital job, they won't take you because you had a nursing home job. And that just is the craziest advice I've ever heard. And my rationale for thinking that that's crazy is thus. I'm a hospital. I've had 3 or 4 years of nurses not retire because they're trying to, replace their 401ks that crashed in the stock market crash. Stock market recovers enough. They've saved enough additional money. They're 67. They're going to retire. And it's going to probably feel like they all retire at once. So now I need all of these nurses. Am I going to hire the new graduate or the person who's been unemployed for a year, or am I going to hire the person who's been working in a nursing home? Duh. Right. So, I think it's like, yes, I know that you're used to the idea that you can hire anybody you want to and just demand that they have precisely the experience that you request. But it's kind of that, we want every nurse that we hire to have ICU experience. Yes, but if you don't hire any new graduate nurses, none of them will ever get ICU experience. Go figure it out. And they will. They'll figure it out. It's just, it takes them a while. So I agree. So the observation is that that there are these financial incentives towards trying to improve the number of primary care providers, but it certainly seems like they're pretty small compared to what we think we need in primary care, and is it even possible for it to be enough versus broader strategies? And I would agree with that. I think that these provisions about, we'll give rural providers a little more money, we'll do some loan repayment, those things are all good. We're glad we're doing those things. But there is still this problem of, as a primary care provider, you basically are getting reimbursed by the number of patients that you see on what are probably 10 or 15-minute visits all day. And even if you wanted to go into primary care because you love seeing patients, do that for 10 years and you're probably burned out. It's very hard work. It's very rewarding work, but it's very hard work. The payment model basically drives you to a kind of practice that you probably isn't what you envisioned when you went into the field. And there is a need to think about this whole payment reform. So, the medical home model is one way of thinking about, what if you pay a group and you actually pay the group in a way that it's not every time the doctor sees the patient, they get X amount of money. It's more of you almost have to go to capitated payment, which I know is a bad word in some circles. But if you had kind of a bundled payment or a lump payment and said, look, if you can manage this panel of patients at a high level of quality and make sure that there's you have a team of providers who are meeting their needs from education through monitoring, through complex care and pharmacy management, then we'll give you some bonus for doing that. That kind of a payment model seems to be more promising to me to attract people into the field of primary care and to retain them from a long-term practice standpoint. But it's going to take a while, yeah. Right, so the question is, does Kaiser have a better retention rate than other healthcare organizations or medical groups? I'm not sure what their data looks like. I'm not sure they'd share it. But my impression is that they have reasonably good retention. But they do, so their metrics overall for physician performance there is some volume expectation. And there also are various quality metrics that go into their payment system. But a lot of what they do in quality improvement comes down to almost guidelines and social norms, as opposed to, we're going to penalize you if your outcomes are X, Y, Z. But they're a pretty complex organization. What's very interesting is, but last week I was doing the grand tour of the Opolis's. So after I went to Minneapolis, I went to Indianapolis, where one of my dissertation committee members is now a professor. And she and I were trying to explain to other people in Indianapolis what Kaiser is and what they do and why they work, because they hear HMO and their vision of HMO is completely different than what your vision would be if you were from Hawaii or California or Portland or one of the Kaiser states. And so it was very interesting trying to explain then, because they're kind of like, so doctors like working there? And it's like, the ones who are fit really like working there. The ones who aren't a fit quit and go somewhere else. I mean, it's, you know, and well, what about patients? Well, the patients who like that model of care love being Kaiser patients. And, you know, and that's why I think they do well in the Medicare market, is you get people who've been in Kaiser for 40 years and they go on to Medicare and they want to stay on Kaiser. That's my mother-in-law. Who lived in Hawaii most of her adult life, and then moving here, she was like, oh good, I can still be in Kaiser. I think she still has the same member number that she had in Hawaii. It's kind of scary. But it's, you know, these different preferences. So while as much, if you like the Kaiser model, or you're, you know, and you think that that's a good one, you really want to say, shoot, you know, why are we pussyfooting around? ACO means we should all be Kaiser and just call it a day. We'll save money, we'll get good outcomes, and there you go. What's so hard about that? But some people really hate that model for whatever reason. Some people just really don't want to be in that model as a patient or as a provider. So it's an interesting heterogeneity that we have to deal with, or variation in preferences. And I think I would have liked to see health reform lean a little bit more towards a Kaiser-esque model, but you know, I'm a Kaiser enrollee, so my preferences are already known. You know, we'll see what happens.